Okay, guys. Uh, we have some people that are here to present, and we also have some that are going to join us by Zoom. So let's get started. We'll call this unofficial committee meeting. This is we don't have a bill. We don't have. This is a learning committee meeting that we will. I guess that's a good way to call it, a learning committee meeting. It's a good day to be alive. And I say that with little mixed meanings. Um, one of the things that most people don't ever want to talk to you about is dying. And I think perhaps that many seniors, as they age, also don't think about it. We spent 3 or 4 years before we could get an acceptable directive on what kind of care and what people wanted to have happen to them. That is now in our law. It's being used by hospitals and across the state. Hopefully, we'll find out how much it's being used, or it could be just like mine. That's with my lawyer. But but everybody knows what I want, but that's really not a good place to start. So I was approached. One of the questions I got is, how does this come about? I got called, coming in. You're right on time. And I will tell you, the people that are listening and have to this committee meeting, that I have really a lot of our senior members here from both sides, people that have served a long time and certainly know the legislature well and are very involved in their districts and in the work they do here at the Capitol. So I'm very thankful once again for everybody that has made this trip. It's a good representation to look at this. And many of them have come from a long distance, or even if it was just from net and they fight the traffic, it seems like it's a long distance. So how this came about is about 2 or 3 years ago, I got a call from Johnny Isaacson's son. You may know that he runs senior living facilities. And he has a very large one in the outskirts of the metro area that goes from independent living, assisted living, memory care, and nursing homes. And asked me if I would come and talk to a group of seniors that wanted to talk to me. And I said, sure. They want to have lunch with you. And so, since they were seniors, I asked the head of co-ed to go with me. And we went out and we had a lovely lunch with about 8 ladies. There was a gentleman that had wanted to come, but he was very sick. And what they wanted to talk to me about was a medical aid in dying, that choice. They said that it was a choice they didn't have in Georgia. And I said, well, I haven't heard about this and I don't know a lot about it. And, how many seniors feel this way? Why don't you? And they want to meet their legislators. And of course, I did my usual spiel that says, well, you need to get to know you're the one that actually represents you and your senator, first of all. And then, you can move on to others. And so I also said, why don't you join the co-age group? And I said, it costs $10. And I said, they meet every year and they look at issues that seniors want brought before the legislature. And so, but why don't you join and really start, paying attention to what they're doing? That would be a good group. It's made up of seniors. Little did I think that in 1 year's time, they would have gotten enough other people to join for $10 so that when the voting came about, this became one of the priorities for co-age. So this is how this all started. And like I said in my email to you, it's something that I didn't know anything about. I've learned more. Amber did a research for me. You've got it in your paper. And so what I decided to do is today we would have an experience where we would learn more about that topic that seems to, as they think, is missing from an option for seniors in Georgia, which is not legal in Georgia, but also to look at what we have in our other options for seniors. So with that, I'm going to let them go first since the seniors that wanted us to look at this are the ones that, sort of got this started. And I'm going to ask Dr. Mims. Dr. Mims is an MD, very active in the Georgia Council on Aging, very learned about this issue. And Dr. Mims, you want to come to and do your presentation? And we're not going to do it?
No, Dr. Mims is going to do it. I was just going to do a little brief intro on Georgia Council on Aging. Thank you so much for introducing us and having us, if that's okay with you. Okay. So I just want to say good morning and thank everyone here, Chair Cooper, as well as the committee members for taking the time to be here today. My name is Ashley Burton, and I'm the Deputy Director for Georgia Council on Aging. As she mentioned, our agency is an advisory body serving the Governor General Assembly and state agencies on matters affecting Georgia's aging population. We advocate for and elevate the issues brought forward by our diverse membership of advocates. As she mentioned, the Georgia Coalition of Advocates for Georgia's Elderly, or COAGE. While today's topic, medical aid in dying, can be controversial, our purpose is not to take a position, but to provide education and ensure issues affecting older Georgians are heard. This issue originated as a 2023 COAGE priority, and during 2024, the 2024 legislative session, we sought a joint study committee to encourage informed dialogue. We deeply appreciate Chair Cooper's willingness to convene this hearing, demonstrating her commitment to open discussion and the legislative process. So it's my privilege to also introduce Dr. Adrienne Mims, our GCOA Vice Chair. Dr. Mims is a geriatrician with over 30 years of experience in health equity, quality measurement, and value-based care. She serves as Chief Medical Officer of Rainmaker Strategic Solutions, is dual board certified in family medicine and geriatrics, and is a nationally recognized leader in improving healthcare outcomes for seniors. Dr. Mims will now provide an educational overview on medical aid in dying to help inform today's discussion. Thank you.
Good morning. It's a pleasure to be here, and I want to thank each one of you for allowing us to have this opportunity to provide this education on this topic and to open the topic more broadly so that we understand all the different aspects about dying in Georgia. So, Madam Chairwoman, thank you very much for hosting this hearing. So I do have a set of slides. I hope that you can either see the PowerPoints or you can see the slides. What I hope to cover today, you do? Okay, great. Okay. I'm going to really define the term MAID, medical aid in dying, and really describe how it's being used in a legal context throughout the United States and in medical practice. I'm going to clarify some circumstances where people choose to use MAID and choose not to. We'll go over a little bit of MAID in Georgia, and then I want to go through the actual process in a state when it is legal. What are all the steps that go along with it? So it's far more than just a law. When we think about end-of-life options, there are several. If you are told that we have exhausted everything we can so that you can be cured, and that you have only 6 months to live, there are several options as you see here. You can say, well, I can continue trying medical treatment. I want to go find studies that I can be involved with. So that is an option. You can refuse all treatment and just stop. You can discontinue care. We have the option of palliative care, which are board-certified physicians who are able to counsel one on symptoms around the time period of death. We all have the benefit of hospice, which is quite robust. I will mention, but I know some of the other speakers will discuss it in far more detail. We do have the ability to voluntarily stop eating and drinking. A person toward the end of life can just stop eating and drinking, and in short order, they will die. Conscious sedation is also available. This is generally done when the person has some protracted pain or suffering, and so that's an option. And then there's medical aid in dying. So let's talk more specifically about it. This is a medical option where a terminally ill person who is mentally capable and is told that they're not going to live more than 6 months. They have the ability to obtain prescription medication that they can self-administer and die peacefully if they choose that option. What it is not is some other terms that are rather misleading, like a suicide or euthanasia. Those are people who are not terminally ill. They're not dying, but they have a medical option. MAID is not euthanasia. I want to delve a little bit more deeply into the requirements that are used throughout the states who have passed it. Number one, it's only over age 18. It has to be an adult. You have to have a terminal prognosis, such as only 6 months to live. And that's a little bit of a challenge, but physicians and hospice people, we're used to using those guidelines that we think that you're probably not gonna live beyond 6 months. And we're fairly accurate. It's usually far less than 6 months, but that is what that part is. You have to be able to self-administer the medication. It's in front of you. You have to either drink it, eat it, or be able to put it inside your rectum. It has to be a person who has shown the capacity to make their own medical decisions, that they cannot be coerced. And it has to be a person living in the jurisdiction. It's usually by state, though, as you'll see, some other states have added people who were not within their jurisdiction. Let's think about what's the liability here once we pass it as a law. Once we pass it as a law, no one person has the duty to participate. You're not required to do this. So if this is my patient and I don't feel comfortable doing this, I'm not required to do this. If there's a nurse who's already caring for the patient and they're asking to do this, they're not required to participate. The family is not required to participate. There's no liability for the medical team or other people for doing this in good faith. So thus, there's no disciplinary action that's taken on the part of those who decide to participate. It does not constitute suicide, mercy killing, or euthanasia when it is passed as a law. It cannot affect your health care in terms of your health insurance or your life insurance when it is passed as a law. So since it's been around for quite a few years now, let's just kind of look at this map here in the slides. I guess we're about slide 9. This has been going on for some time, and the first state to pass this was Oregon. And as you can see here, there's been almost a decade before others began to take it up. There's more than 11 states plus the District of Columbia who have passed this into law. And as you see on the map on the right-hand side, there are several other dark colored states who are considering this legislation. But let's look more closely at the people in Oregon who got a prescription since this law was enacted in 1998 to 2024. So in the chart here on slide 10, if you look all the way on the right-hand column, this tells you the total number of people who took the prescription. It's pretty equal, men and women. Very few younger people. The majority of the people are over the age of 50 who are using this. So of the people who are using it, who have a terminal illness, you can see the demographics there. And what we find is, although more than 4,000 prescriptions were written, only 66% of those were used. So it is a choice. Sometimes people feel it's empowering to be able to have that option. Most of them, as you see here, 69% had terminal cancer. Some had neurologic conditions or end-stage heart or lung disease. The vast majority, 91%, died in their own home. 6% in assisted living, less than 1% in nursing home or hospital. So this allows a person to die at home. 1% were also enrolled in hospice, which is a wonderful benefit that can be accompanying this. But this is in Oregon, and the data over those years of people who had the prescription and used it, 91% were already enrolled in hospice. Average age was 73. So hospice, as we mentioned before, is that benefit when you have 6 months of life to live. I want to really focus on this wheel here. It's important to note that hospice is very robust in terms of the services. It's led by a clinical team. It has nurses and aides. It has spiritual support, social workers, other types of therapy, and volunteers. And it has grief counseling for the person and the family members leading up to this, during the process, and afterwards. In Oregon, 91% of the people who took the medication were already on hospice. So they asked them, so what were the reasons people chose to take this medication? And you're already on hospice. So as you see on this graphic, 90% said, I don't want to lose my autonomy. I just don't want to go through this end stage period of life where I can't do anything for myself. I don't want to lose my dignity. I don't want to have a lower quality of life. I'm afraid that I may not have adequate pain control. And it's not any one, it's several of these reasons. So that when a person has a terminal diagnosis and they know there is nothing more that can be done, and they are going to die based on what all people have said, they've said, well, okay, but let me pick the date, have a party, and go. So as I said before, as you see in this graphic, there were many more prescriptions written than were used. And that has been historically the same over time, even a larger gap. Let's look at the changes that have been made to those existing laws. They were passed at one point, but they've been modified. Oregon was first. So they passed it in 1997. But they realized over time they needed to do a little tweaking. And so they said, we initially had a 15-day waiting period between when a person can ask for it and use it. And so they said, well, let's get rid of that. And they then in 2023 said, you don't actually have to be a resident of Oregon. When we look at Washington State that passed it in 2018, they made some changes to their law in 2023. They said there may not be enough physicians available to participate, and many people have advanced practitioners as their qualifying person. So they added qualified medical clinicians or practitioners, QMPs, as also being able to do MAID other than just physicians. They also said that you didn't have to go to the pharmacy to pick it up. It can be delivered to you by mail or a messenger service. They said if one clinician felt that they were not going to be available or no longer wanted to participate, they could transfer the care to another qualified medical practitioner, and it would not start the waiting period over again. And like the other states, Washington said, well, let's reduce the time. 15 days is kind of long. Let's make it only 7. And they adopted electronic medical records for documentation. Interesting, Vermont, they also removed the in-state requirement as a resident to be doing this. They made it only 48 hours as a waiting period between when you first ask and can get a prescription. And as I said before, you don't have to be a resident of the state. California, They initially passed theirs in 2015, and 3 years later, they had a major challenge against it, but it was upheld in the law. They reduced the waiting period from asking for the prescription and getting it to 48 hours. They eliminated some of the paperwork. They also required that healthcare entities that participate with MAID, that they need to make that publicly known.
Borrowing time things again, we moved a little bit less. You're going to have lots of questions, I think. I think you and I wanted to be able to ask them. So the other states that may be the history of Georgia are not going to go, you tell us not necessarily. So
I'll go a little faster. Hawaii, again, they allowed advanced nurse practitioners. And I want to mention Florida, since it's a local state. They had it as part of their legislative agenda, and it was posted for 2 committees, but it wasn't heard this time. So let's talk a bit about Georgia. Initially, back in 2011, a chapter of organization Compassion and Choices that helps to spur MAID adoption across the states was established in Georgia. But after 5 years, 8 years, it wasn't very active, so it disbanded. Then another group came together back in 2020 and proposed legislation, but it didn't get very far. So in 2021, a new group formed that had a chance to speak with Madam Chairperson. They called GALO, Georgians for End of Life Options. And they, as an independent group, came together to promote the possibility of MAID. Sorry there. So in April, they submitted it as an agenda item for COAGE, and I am with COAGE. It was adopted, and we decided that first we needed to educate people about it. And then finally, it's come together so that we could present it in a work group. I also wanted to say that as a physician in Georgia, I took this as a resolution to the Georgia Medical Association House of Delegates. And MAG, or Medical Association of Georgia, adopt a resolution that is pretty identical to the one that's been adopted in all of the states that have already passed MAID legislation. Number one, physicians need to lead the care at the end of life and respect patients' autonomy. And resolve number two, that they adopt the position of engaged neutrality regarding MAID, because they understand and want to protect the physician's freedom to participate or not participate according to their own conscience. Also, we have statements from the American Medical Association that most recently has referred it for further study. But there are several other medical associations who have engaged neutrality. Academy of Family Physicians, the American Academy of Hospice and Palliative Medicine, Neurology, and as I said before, all the states that do this. I'm going to walk through what the process is so you're aware of what we're talking about. And once a person presents and say that they want to have MAID, they present this to anyone, and it has to be documented and understand why they want to do this and really reaffirm that that's what they want and talk about all the options that are available. Sorry. There's 2 times the person has to make the request, not once. And initially the laws say they have to make that request to the physician twice, 15 days apart. It doesn't have to be in person, and it must be voluntary. A second physician also has to corroborate, so a consulting physician must be seen. The person's request has to be a written statement. And as you see this example here, in some states, they formed a patient form that can be used to identify the 2 witnesses and the 2 requests for it. The physician themselves have to document that the person is mentally capable and that they meet all of the criteria. And if they think that the person might be depressed, they can send them to mental health if needed. They have to examine the patient, put it in the medical records, and confirm that it is okay to do this. And every state that has passed it, they have their own form to do this. If a mental health evaluation is required, we're trying to determine are they capable to make their own decision and that they're not depressed. Health insurance, federal health insurances do not pay for the medications. The actual cost for this prescription is between $750 and $950. And it's done through a compounding pharmacist. So there is some cost. So this is what the medications are. If you see on this slide here, 36, it's in two different groups of doses, and they're compounded into a liquid form. So there's one group that you take an hour in advance on an empty stomach, and you make sure that they can still take their pain medicine. And then at the time, you drink a liquid that compounds all these other legally available medications together. They usually lose consciousness in about 10 minutes after that second dose I mentioned, and they die within usually an hour, rarely longer than that. So it's important to give guidance to the family to what to expect. And it's great that most of them are already on hospice. Now, anybody can opt out of this, even if it is in the law. Patients can change their mind at any time. And everybody is protected from criminal and civil liabilities. You still have to sign a death certificate, and the death certificate says the terminal diagnosis, not anything else. And it's respecting autonomy, relieving suffering. It's a very safe medical practice, reduces stress for the caregiver, preserves dignity, and emphasizes quality of life. And at that, I will stop, answer any questions now or afterwards.
Okay. I'm okay. Let's do about 10 minutes of questions, but then you won't be off the hook. We'll just move along, and then because one of the presenters has to leave by 11:15. And
Thank you.
okay. All right, go for it. Who Representative Barnes.
Thank you, Madam Chair. Thank you for your presentation. It was great. I had a couple of questions, but I'll stick to this main one. What if someone chooses to take the cocktail or chooses to participate in MAID, and then they've received the drugs and then they choose not to do? Is there a process on collecting the drugs? And also with the shipping it in the mail, regular mail, is there some type of security process to ensure that a kid doesn't get the mail that day and
Very, very good questions.
get interested? So do they have to ship it back, or is there some type of process if they choose not to use it? Thank you.
So across the state, we have medical disposal places for opiates and other drugs. And so we would invoke using those that already exist. There are some at police stations, there's some at certain pharmacies where people can dispose of them. I'll also ask when our hospice people come up, since they leave a medical kit that has many of these same medications in it in the patient's house, what do they recommend that the people do to dispose of them? So it's not unusual that lethal medications like this are available in people's homes. We already have that within hospice. And so we would want to invoke the usual process for disposing of them. Now, your question was, what about if it comes in the mail? I think we would have a chance to really decide if we want to do that, but I don't think it's necessarily the mail one would do. But remember, in COVID, we got into a situation that pharmacies did deliveries of medications. And so being able to protect that you can use a delivery service for medications is more, I think, what that would be entailing.
The other question Dr. Barnes was Representative Barnes was asking, Dr. Mims, was, okay, so somebody takes the medicine, the first one takes the second one, and all of a sudden says, whoa, wait a minute, I don't want to do this. Is there an antidote to it? Is there any way to stop that process? Is, I believe, what she was getting at, sort of? Part of it.
of it, but also if they get it and choose not to do it, like I feel like it's unsafe to just leave it sitting around the house. So we would have to put some precautions in place for them to properly dispose of it and just to make sure it's disposed of. And also, who pays for this? Like
It's
the
private
state,
pay.
private pay?
It's private pay. The disposal is the same mechanism of disposal as hospice would do, especially since hospice is in, and since they're going to speak today, I'd rather have them address that part. But your question is, after they ingest it, if they change their mind, there is no recourse. This is a person who is terminally ill, who is going to die. If they take the medication, they'll become they'll become unconscious within about 10 minutes. And so there is no antidote to it. That's correct. There is no antidote. It is permanent.
Good questions, Representative Hilton.
Thank you, Madam Chair. Thank you for coming down here. I'll start with that. Thank you for this excellent data. I'm going to ask a couple pointed questions. And the reason I am is I'm a blank. I'll lay my cards on the table. I find assisted suicide morally abhorrent.
Mm-hmm.
And I'd imagine a lot of Georgians probably feel the same way. When we had our first child, he was tested a number of times. You have a healthy baby boy. He was born with Down syndrome. I share that story. Medicine doctors, they don't always get it right. You've shared data from Oregon here. Have there been any autopsies or post facto? Have we found that, maybe we have gotten it wrong in certain, and maybe that diagnosis of terminally ill wasn't accurate? And what sort of message does it send to our seniors that, hey, your life in the final 6 months isn't going to be great. Go ahead and terminate.
Okay, thank you for the question. Sure. That's why it has two physicians has to certify that the person is terminally ill, not just one. And so the person who's seeking this usually, like if they have advanced cancer, which is the largest group, they're oncologists and their treatments, they have been told there's nothing more that we can do. We really have nothing more. So in that sense, that's a normal process and people are going to die. It's a subset of people who choose to decide when. I understand the ethical dilemma, and for many physicians, it is an ethical dilemma because when we are sworn in as a physician and take our Hippocratic oath, it says that we will do no harm, but it also says that we will respect patient autonomy and patient rights. And there's been revisions to the Hippocratic Oath over the years, and many things have happened in healthcare where we can prolong a body living for a long time that may not necessarily be what one would consider personally their own quality of life. So it's between a patient and their personal physician. If the patient makes a personal decision of what they would like to do, and that physician wants to uphold their decision, that's where this happens within MAID. It should be a narrow personal decision.
In the states you highlighted, I didn't see any. I was looking for how do we prohibit financial incentives from coming into play here, either from the family who is maybe seeking to benefit from that person passing, or, for example, insurance companies who may begin to push this as a cheaper option as opposed to prolonging life.
That's interesting. Well, the patient has to actually ask. None of those people can ask for them.
Well, I can push grandma,
Well, I mean, then that's up to your ethical conscience. And I think that we really need to make sure that the person who is terminal is supported and that they have all of the necessary counseling and coaching around them. And so having hospice there with them so that they understand what the dying process looks like. And if they know that they are terminal, if they choose to make it Friday at 4:00 as opposed to within the next period of time, it's a personal decision. Madam Cooper mentioned that we have in Georgia come about Georgia Advanced Directives for Healthcare, where we can actually say when we want to allow a natural death or we want to have resuscitation. We have passed physician order for life-sustaining treatment so that the medical community will honor a person's healthcare advanced directives. This is a different advanced directive. And so it's the subset of people who that is their preference.
Yeah.
Between them and their physician is a personal decision.
Again, and I'm not worried just about the family. I'm worried about insurance companies too, who begin to push this as an option. I'll end with this question. What's to stop us from expanding this to other vulnerable population groups, maybe folks who are confined to a wheelchair their whole life or mentally incapacitated their whole life? Why not include them as well?
Because they can't make that decision themselves. I mean, that's the basis of all of these laws, is a person has to be mentally capable and make that decision themselves.
So let me change my example then. Yes, maybe it's someone who is has some physical but they're mentally fine, but just that's not the quality of life that they would like. Should we expand it to them?
It's not my personal decision, but some states are asking, what about people with advanced ALS who cannot use any of the rest of their body? Right now, the states have not amended it to include them. The other group that it comes up a lot is dementia. So we know dementia is a terminal illness. We know the progression of dementia, but dementia, it does not qualify because by the time you're 6 months prognosis with dementia, you are not in your right mind. You can't make that decision. So it doesn't really apply to several groups of people. Thank you.
Okay. Thank you for allowing me to, and thank you for coming here presenting.
Sure.
Yes, ma'am.
Another question if you got it till later.
I'm done.
Okay, Representative Howard.
Chairman, and thank you for your presentation. A couple of questions. At the point of a physician telling a patient that they are terminal, who educates them to this process? At what point are they educated to this process of end of life?
Okay, so if it is legal in a state, the healthcare team, the physician, can make that available. If it's legal in the state, local constituent groups will have websites that tell people about the existence of this law and how to actually enact it. So in all the states that this is a law, they have these public-facing websites that tell you, you have the right to make this decision within the state. This is what the process is. If you want to do it, you have to initiate and go and ask. It's unlikely that the physician's going to necessarily come up with this themselves. It's usually a patient must make the request.
Okay, now the second part of my question is the mental health piece. Is an oncologist or that physician, are they qualified to make a mental health diagnosis, or could this be like something mandatory? Because if I'm told that I have 3 months to live, I'm probably automatically going into depression. So how do you monitor that from a professional standpoint rather than just I guess getting them to a specific psychologist or whoever to make that designation whether they have mental problems?
Excellent question. When a person is told that they're going to die, they do have a reaction. And oncologists, palliative care physicians who deal with patients who are terminal are experienced in working with the patient through that initial grief. And most of the people in primary care, we are trained to treat depression and identify and diagnose depression versus grief. However, if we have any question and a person is coming to us and asking to die, and we're not sure which one it is, we always have that option for a consult. In the state of Hawaii, it's actually mandatory. So there is some variation. Thank you.
Oh, okay. Representative Jordan, I'll make you the last question, but Sharper, can you hold it till we come back? Okay, Representative, go ahead.
Thank you, Dr. Mims. What a hard topic. Who knows how we respond since we've never had to respond to this issue personally today. I am uncomfortable with this, just like Representative Hilton. However, I would like to go back to your data and using Oregon as the example. And you have a 26-year data set. Roughly very small percentage of people use this option during the year, during that time period. It's like 124 people over that time period per year. What do you see this as the expected number of people in Georgia that could perhaps be benefited by this particular choice?
As in most states, it's a very small percentage. And in Georgia, it's probably less than 5%. But of those people, if it's you, you want to have your own personal decision and the rights to make your own decision. So as a geriatrician, I've been there at the end of life and having terminal diagnosis with patients many times. But as an older adult, having parents, having siblings, having neighbors who have died, the dying process is going to happen, right? And we've all had this experience, and we know of people who have died, and we all want to die comfortably in our bed at home asleep. But that's just not the reality. The reality is far too many people end up dying in the hospital, in the ICU, with tubes in every orifice, and the families down the hall arguing. There's so much difference than what we may personally consider an ideal death than what actually does happen. So we're really glad that we have healthcare advance directives to try to alleviate that. We have implemented POST, a physician order for life-sustaining treatment. And I, as one, was involved with both of those things before, right? So I think that this is another option for a subset of people who want to have that level of autonomy around their death. It's not for everybody.
Thank you, Dr. Mims.
Thank you very much. I'm going to stop us right now, but everybody think about your questions. Dr. Mims, okay. And I'm going to skip over, and I apologize to Ms. McNeil. I'm going to ask for the next presenter because I have to leave early. Can you stay and still there? Okay. Because we certainly want to hear from you. We have Kathy Kinlaw, and I'm not sure, is it Dr. Kinlaw? Yeah. Okay, and she's the Associate Director of the Emory University Center for Ethics. And just relax, we're not trying to put you on the spot. But I'm so appreciative of you coming, because sometimes in the past we have asked Emory to help us. And we're not experts. We bring our life experiences That's all to the whole legislative process on every issue. And often we do need to come to people who deal with it more directly on a specific issue. And in the past, sometimes they don't want to go down, they don't want to get involved. They're afraid so there'll be some pushback. Well, if there's ever any of that, let me know who did it, because I'm coming after them. Because otherwise, we lose a very valuable resource. So in that respect, I would ask, one of the questions that I could ask Dr. Mims, or her response would be, okay, it's $750 to $1,000 in cost. A lot of people can't afford that. When we see that circle of what hospice says they give and who all's available, counseling and all that kind of, we don't have that in South Georgia or North Georgia. There would be big holes in that circle of what's available for people. I mean, hospice people do the very best they can. I'm a registered nurse with advanced degrees. I don't understand how people that work with the dying on a regular basis can do it. I've certainly seen people die. I've held their hands. I've seen children die post-op and open heart surgery when it was first new. It's horrible. I don't see how people deal with it every day. And I am thankful for those that do across our state. And if they're listening, thank you very much for working with people in that stage of life. But we really need to know about the ethical thing when we can't say that that service is available all over Georgia, that we can't give maybe all the counseling that we need. How can you help us on this? Because it is, like I say, you're looking at really people who've been here a while. Like I said, who take their jobs, they're senior people that take their jobs very seriously. And I can tell you, I wasn't sure who I get here, and I'm so thankful to my committee because we want to listen, but we need some help. Can you help us out on this, please?
Well, thank you very much for the invitation, Representative Cooper, and for all of the committee members as well. And I have a few slides. I don't know if somebody's going to be able to pull those for me. But let me just say, to your point, I worry all the time. I grew up in Georgia, been here for a long time. I do worry about potential for inequality and disparity in many areas related to end-of-life care. So I understand that completely. Happy to talk further about that. So my request today was to give you some background information related to some of the services that are provided before people are at a point where end of life is they're facing it immediately. So I want to walk you through a little bit of that. I'm hoping, frankly, that most of us in this room know some of this background information. I had the opportunity, as Dr. Mims has as well, to be very involved in the process with advanced directives in the state of Georgia. I co-chaired the working group with about 30 people from across the state with very different opinions about advanced directives, and we created the new, quote unquote, new advanced directive. Also worked on the PULSE initiative, and this is my wheelhouse. I spend a lot of time doing ethics consults in the healthcare environment in hospitals with patients and families who are really struggling with these decisions. So I have a heart for this.
That's what we like. We have people later coming talk about palliative care and hospice and all, but it's that struggle and the ethical part. If you can emphasize that. Thank you.
Very good, very good. So I'll go through a few slides and we can move as fast as we want to. So I think one of the sort of conundrums that we're all concerned about is the level of just quality of care related to someone who has a diagnosis with serious illness. Certainly people who, and I have friends right now and colleagues who are in critical care units, and we've all seen how trying and difficult that can be. And then just near the end of life as well. And we have multiple physicians involved with patients who are dealing with serious illness. And I think that can lead to fragmentation of care. We need to be thoughtful about ways to enhance that. A lot of strain, of course, on family or other areas of social support. Those are just challenges that I think we have to look at as we think about this time of life, which we will all face. And very difficult decisions related to whether we start certain treatments. Does a family and a patient decide we should continue hemodialysis? Should we consider putting a patient on ventilation, on respiratory support? And when do we decide that we've done what we can and respiratory support needs to be withdrawn? So these questions related to starting treatment or decisions, and these are so difficult to withdraw certain medical procedures when a patient is indicating, and this is where I think we have great help from our physicians and other providers to say, we have done everything. We've done 5 different protocols of chemotherapy and tried radiation, and all of the collective wisdom is we're not going to be able to benefit this patient. And at that point, really difficult decisions have to be made. And fortunately, I do think we have some good pathways, if you will, for supporting patients there. So most of our healthcare institutions have an ethics consult service. We're just one piece of it. In some healthcare systems in Georgia, we have multiple full-time clinical ethicists. In others, this is again where we don't have as many resources as we'd like. There are hospitals around the state that don't have a full-time clinical ethicist, but may have a team of people on an ethics committee who try to come to the bedside and work through these difficult issues, but very important. I spend a lot of time when I'm at the bedside really sitting and helping families and patients elicit their values. So what's going on for you here? How do we think about this? What's really core in terms of your beliefs, religiously, culturally, familial, so that people can begin to think about how we're going to make this difficult decision? I certainly want to make sure people are well informed when they're thinking about decisions. How much information do people have? Do they have questions? Are we answering those questions? So bringing the team together with the patient or the family, if the patient can't speak for themselves, to really walk through this, we should be answering those questions. And when we don't know, we actually need to say, we don't know, right? But this is what we're going to do in light of that next. So people feel informed and they feel that there's a commitment to working with them. Often we have different conflicting perspectives, right? We have family members who are maybe not on board with each other. And for example, if I have a patient, maybe it's an older patient who have 4 adult children, they all legally have the right to make the decision if there's no spouse for the patient. And they have to come to some agreement. No one of those children would have the right to make the decision over others unless they've been named as a healthcare agent on the advance directive, which I'll mention briefly. But there can be conflicting values. And how do we resolve that? We have to sit and work with that patient and family through those kinds of conflicts. Really important. Yes.
It's even if there's 4 children, and even if the person has the advance directive and it's available that says, I don't want to be put on life support, in Georgia, can those 4 children override that advance directive?
So the advance directive should be honored, right? That's the patient's preference. It's been identified, the patient's written it. Perhaps they've had a chance during the hospital stay to have repeated it multiple times. Sometimes when the patient then no longer has capacity, right? They've declined in terms of their status. Then we're looking to the family. We're trying to build consensus there. We make very strong and bold conversations with those family members to say, remember what your mom wrote down on the advance directive. Now, I'll tell you, in the ultimate legislative decision for the advance directive in 2007, we had to make a decision that if a patient's preferences and the family's preferences differed, and we had an advance directive, that there are some circumstances where actually the family knows that the patient has changed their mind, right? That maybe the advance directive was written 15 years ago. And we listen to that. We try to work through all of that, but we do our best to honor the patient's preferences on an advance directive. So we're spending a lot of time supporting, obviously, the patient, supporting families, but also the clinical team members. There's a tremendous amount of what I would call moral distress that our healthcare teams are feeling and working through because they do care. They really do care about the patient. So when I think about patients, families, and clinical teams, we all have common interest to do what's best and right for this patient. I absolutely believe that. But again, there can be differing opinions on what that looks like. So I think ethics resources are a really important step for us. And then advanced care planning, which we've mentioned, there's some great resources online, and you have this already, but we can circulate more. I think it's really important to think that advanced care planning is not a single event. It is a process. So we need to revisit this all along the way, particularly when someone has a new diagnosis, serious illness. It's a good time for us to be talking about it, but frankly, it also needs to be revisited every year. So if I ask you, I won't, to raise your hand if you have an advance directive, anybody who's an adult can complete one. I've had one for many years, right? So that's important, but sometimes our own preferences can change. And you can add an addendum, and actually every year when you go to see your doctor, you can re-sign an initial that this continues to reflect your preferences. So I would encourage you to do that, in fact. And if really important, if you do reach a point where you don't have decision-making capacity, having identified a person who can be a spokesperson for you is so crucial. I cannot tell you how many times we have people come into the hospital with no identified person to be a decision maker, and then we revert to the hierarchy in Georgia law. But that person may have strong opinions about who should be making the decision. So we try to elicit that when they come into the hospital, and then we encourage them to complete an advance directive so it's really clear. You can appoint your what we call healthcare agent, and we try to encourage people to do that. So it really helps your family who doesn't really want to make decisions, difficult decisions apart from what you want, reassures them, kind of removes that burden from them. So I think there are really important parts of advanced care planning. And so it's not just the directive, the advanced directive, it is the whole process of advanced care planning, which I think is important. And that's an ongoing process. So again, won't go into great detail. Before 2007, we actually had 2 different documents. We pulled together this working group, and it was a fantastic experience. We met every Friday for 6 months, and we came up with a way to combine the 2 documents. So there are 4 parts to it, as you probably know. I just talked about the appointment of a healthcare agent who can then speak for the patient if they don't have decision-making, but also there are places you can clearly put in your treatment preferences. There are limits even on our advanced directive under what situation these apply. So if a patient is in a terminal condition with no hope of regaining any kind of ability to survive and is in an irreversible condition, then you can apply your advanced directive. But there are also, if you're permanently unconscious as a patient, you can identify this is something I want this to apply in. So important there. And then you, in general, the very broad strokes, you're going to identify, I want you to extend my life as long as possible. You can see some of the specifics there. I'm happy to answer questions about that. Or on the other end, I want my natural death to occur. I want you to allow that to happen. I don't want all of these interventions. Or you can indicate in general, I don't want interventions, but here are some specific things I do want. So there's 3 options, sort of philosophical options, but they're, on the document itself. And then of course, witnesses, there have to be 2 witnesses in Georgia for most legal documents to begin with. Dr. Mims mentioned the POLST form, Physician's Orders for Life-Sustaining Treatment. It's been another additional powerful opportunity for patients and families. This bill went into effect in 2015, and this is intended for patients for whom you would not be surprised that they would die in the next year. So they're dealing with a serious illness that may lead to their death, and they know it. And interesting on this document, some of the same categories about cardiopulmonary resuscitation, what medical interventions you want or don't want, and to what degree, artificially administered hydration, nutrition, antibiotics even here, because you're closer to knowing what I want. An antibiotic for that pneumonia that I have at the very end of my life, or maybe I forego that. You can actually put all of that in. But what's very different here is this is a document that's signed by the patient and the physician, so their attending physician who's worked with them. Or if the patient no longer has decision-making capacity, then a family member, an authorized representative, a healthcare agent, or one of the people who are on the hierarchy can co-sign the document again with the attending physician. So there's a real accountability there. And again, it's meant for people who are closer to the end of life. So if we all have an advanced directive now, we're probably not qualified for a POLST. But if you're dealing with serious illness, then you can qualify for a POLST. The other piece of this particular document is it is intended to be a medical order set. So you're giving enough specificity, and so is your attending, that if I came into the emergency room at Emory or Piedmont or wherever with this document, the idea was for it to be honored as a medical order set. We actually have to go through another step, which I think is probably a good safeguard, and that is every patient who's treated in a healthcare system has to be treated by a physician who has admitting privileges to that hospital. And so if I say I'm from Hayhira, Georgia, and I brought up my document with my signature and an attending there, that person, if they don't have admitting privileges at my hospital that I'm at, we have to go through a second layer of review, just confirming this is what the patient would want and re-enter it into the electronic medical record. So some good safeguards there as well. I won't go into great detail because I know that palliative and hospice care will be discussed, but I do want to say we work hand in hand with palliative care every single day. And I think palliative care is such an amazing opportunity. So palliative care is representing patients who receive medical care to prevent or treat a symptom of disease and side effects caused by the treatment of disease, can be done much earlier than end of life. So people are dealing with significant illness for whom they would like to have support all along the way. And support might include spiritual care, it would include a social worker, in addition to a physician or a nurse practitioner or a PA, very involved. Hospice is at the very end of life. It's interesting to me when I go into a room to work with a patient or family who's really struggling with a decision. And maybe palliative care has already been introduced to them, but they think immediately, this is hospice and I'm going to die. And they essentially fire palliative care. Yeah, we don't want you back in the room. Once we work through with the family what their goals are, and again, usually it is the family by that time, the patient's no longer able to speak for themselves, we often can bring palliative care back in to help them understand all the resources that are available. So palliative care is really powerful. There is a way to go online and identify in Georgia, and this is the information, and you see the website there, to actually identify where palliative care resources are throughout the state. This gives you a quick visual. So we have them in, of course, a lot of major cities in Georgia, but we're missing them in a lot of our rural areas. And that's a good opportunity for us to look forward. So you can see here the lower categories in all of these areas. In Georgia's the first section here are rural areas. So very few, about 25% of our rural areas have access to hospital-based palliative care. So again, I won't go into any more, but thank you for the opportunity.
Few questions. Thank you so much for the presentation. I mean, what you're presenting is a lot of support for people. And it seems like to me that before they take that next option, they would certainly need that exploration and help. And right now, it's not that Georgia doesn't want to give it, but we are dealing with not enough mental health workers, not enough social workers, not enough doctors in rural areas. We're trying to correct it. The legislature is producing more kids out of med school. We've started more residency programs. We're trying to get Georgians to stay in Georgia. We're paying back school loans for social workers, that can do it, but we don't have them yet. And I see like the concerns, and I would think also, depending on what your faith is, if you're Hindu or Jewish or something, those things have to be taken into consideration. It's just things that, as I've learned more about that, I think I'm worrying more. And I can't, anyone listening that doesn't have advance directive or any of our members that don't have you really should do it. But there are even times, and I will tell you, I went through this with my husband. He was having a heart attack. He had a terminal illness. And a long thing, no known cause, no known cure, and he was having trouble breathing. Also ended up having a heart attack. Quickly, they took him to the hospital, whisked him off to surgery, and he went bad in surgery, and they put him on life support. One of the worst things I've ever been through in my life is when they told me I had to make the decision. I couldn't do it. And nobody came to me at one of the biggest hospitals here in my home county to try to help me make that decision. And finally, the physician that was no longer on their staff, but had just changed over to be at another big hospital, their group, but had taken care of Tom and was Tom's friend. He was a physician. My husband was a physician too. Stepped in and made the decision for me with Tom's help. And just as they were telling me I had to make the decision, he got worse. And I do truly believe that he tried to help me make that decision. So going to surgery, they said they were required to put him on life support. So there are things that we need to look at in case that it's very hard, because hospitals too are worried about being sued or, having families that are unhappy with them. So thank you. Questions from the committee?
Thank you for sharing your story.
It's,
Thank you.
you can tell it's been 13 years in November and it's still,
Fresh.
but I made it and it was an experience. So we went through it. Representative Hilton, who you want to go to? Dexter, go ahead.
Thanks so much for being here. I've been in the medical field 38 years. And one thing that I'm looking to hear, and I don't want to mix the two up, so I'll talk to you probably offline or later on at the end. But when we see a lot of the DNRs and we get to a person's home, how much are y'all educating them to make sure they have that actual paperwork? Because if paramedic goes to someone's home and they're saying, revive them or help them or somebody in the house, and we're like, all right, do you have a DNR? Where is that? Where are the, your papers?
Yes.
We still have to do what we have to do until something is produced. How do, what's the education like on that end of the people that have the DNR, the healthcare experts?
I'm glad to know you're working at that juncture. So thanks to you also. Yes, I think this is a big issue. I'll say when we did our advanced directive initiatives, now a number of years ago, and PULSE initiatives, we actually did a lot of training with EMS in the state of Georgia with the state office and tried to provide information. And we were encouraging people to have a plexiglass magnetic thing on their refrigerator, or in many assisted living and nursing homes, it's by the door where you put your information there and it's immediately and easily accessible. I think we need to do a lot of education again, and you could probably be helpful to us in that. It's got to be available.
Yes, we got to know.
Yes. Thank you.
Education is so important because there are different EMTs now, and I think that on a lot of things, getting the word out again. Anna, do you have any statistics on how many advanced directives you really do get and use in the hospital just quickly? No? That's it? Okay.
I can tell you it's probably much less than 25%. Most of the hospitals that I'm at, where we have a network of hospitals in Georgia, and I would say it's less than 10% in most. I think there's opportunity for advanced care planning initiatives statewide. Yeah. Okay.
Representative Hilton.
Sharon, thank you for sharing your story with us. People often ask me, why do I enjoy serving down here? And it's because we have the opportunity to weigh very weighty issues like this. And so I want to thank everyone who's here to help us do that. I am going to put in a quick plug for my wife. I'm married to an estate planning attorney who can help all of you with your advanced directives. Yes, meredithheltonlaw.com. Yeah. So please give her some business. In all seriousness, I'm honored that we have an ethicist here, and I'm going to ask you a question. If it's outside the scope of kind of what you do, you tell me. This body has done a lot around mental health, especially in recent years. And can you expound on sort of the ethical dilemma it would create if we as a state, as a body, were to say, you as a senior, if you're facing a life-ending situation, you have the opportunity to kill yourself. Now, what message does that send to someone who is struggling with serious mental health issues, who sees that as a policy position of Georgia and decides to maybe that gives them a green light to take their own life?
So I'll just say in general, I think the whole question of aid in dying is a very controversial one, and we could talk at length, and I would actually love to talk at length with some of the folks in the room here. When it comes to mental health, serious diagnostic in mental health, I think we do need to think of those individuals as potentially very vulnerable, and therefore to be very protective of those particular individuals. I would be concerned about the way in which we would have such a conversation, or how we might encourage them to maybe think about their end of life in a different sort of way, rather than moving quickly to that. And for all of us as Georgians, I think this issue of knowing what resources are available to us and making sure we have, and this is a challenge, we have trusted healthcare providers who can help us think about all of the possible resources available to you, that's really an important priority for all of us. And then we need to think about the vulnerability of certain patient populations, people who are living with disabilities, people who have significant mental illness. Those are places we need to sort of slow down, talk to people who are advocating in that arena, and learn. So, yeah.
Thank you. Thanks for your presentation. I was wondering how many changed their mind after that bedside ethics visit.
I'm not sure I'm changing minds as much as helping them discern what is it that will best honor their own values and beliefs. So I'm not trying to say if their thoughts are either, many people really seriously don't have a decision. They just haven't made one. And I'm not trying to persuade them either way, to be honest. So
Do some have their mind made up when you come visit and then decide not to do it after your visit?
it's not like,
not
it's not, as I say, it's not a single question. It would be a ongoing kind of conversation. Certainly people, I think, sometimes get better informed. So if I continue this aggressive procedure here, what is the potential outcome? We're going to have everybody at the table, so they're getting that information, and maybe that shifts their sensibilities a bit. But my goal is not to persuade someone to do something. I'm trying to help them make the decision they can live with.
Thank you.
That's all of our questions, but the mental health is one of mine too. And I just happened upon some information about the shooting at the CDC. A dear friend of mine knows one of the neighbors personally. That young man who shot up the CDC had obviously had, little odd. In fact, for my friend, he used to cut the grass for him. But for this other couple, he had never caused any trouble, they said, and so forth. But 2 weeks before he shot up the CDC, he was looking after their dogs while they were out of town. And the weather turned bad, and he knew that those puppies were really upset when storms came in. So instead of just letting them out to go tinkle and feeding them, he stayed overnight and through the storms with the dogs. I mean, he was a kind person, but believed that, and had obviously mental problems, thought that the COVID shot had caused him to have all sorts of problems, is apparently what they said he was talking about all the time, who decided, I think, to die by police, by hands. But a scenario where I think sometimes people do, I want to kill myself. I can't do it. So I'll just go cause a thing where the police will kill me. But it's a mental illness, and somebody can function, even though not at 100%, but obviously was functioning and kind. And a young person then reaches the state where he decides to take on the CDC and the police and kills a police officer, and while he also, gets killed himself. The mental illness is just
This is enormously important, and I'm so glad you all are thinking carefully about
like
it.
that. So it's something that we deal with so frequently. I mean, because after you read it, you think, oh, how terrible, he was awful and everything, but there's a human side to that. There was that kind young person on one side, and then the sickness and the illness on the
And that's
other,
often true, I think, in mental illness.
in the middle of it. So thank you so much for coming
You're welcome.
and helping us and learn more about this issue, and it's greatly appreciated. Thank you. And I
I'm glad you could be
appreciate
here. Thank you.
Sydney getting Emory to allow us, tell whoever has changed their attitude over there, maybe thanks to Sydney working for us, how much we appreciate it. Oh, Sharper, I'm sorry. Did you come up with one more question?
One quick question. And this is where I am. We're looking at the MAID presentation of what's going on. After the point where you have the DNR signed and all that, let's just say you're good to go. All right, at what point or how would you guys say, hey, look, here's another option? Do you think that will come at that point where you're saying we got the DNR, everything's in place? Then would you go ahead and say, we also have this option, the MAID option? how would that work in a sense?
Yeah, I think, as Dr. Mims said, that patient bringing it up to their physician is more likely. And a person who is, it's in serious illness and toward the end of their life in the inpatient setting, that is not something in general we would bring to them. We would certainly talk with them if they brought it up with us.
Okay, so what would be the difference in a sense, just open wide, that all of us that are getting older, okay, and we want to do the advanced directives, right? So it's normal for staff or someone to say, look, you're in a bad situation, or you're not in a bad situation. You just want everything up ahead, up front. These are my wishes. And then you get to the step of, all right, let's talk about your DNR because this is what we're looking at, okay? Now, why wouldn't you have that made if we were able to do something like that? Why don't we also have the MAID as an option, not for just the patient? Because most people may not have a clue about it at all that is available. So I think the educational piece of that would be, if you have a DNR, now here's another option, not pushing anybody to it, but at least let them know it may be an option. That's if we get to that point.
I think it's worth discussing.
Yes.
And also, just to say, I mean, of course, it's illegal in Georgia.
Right.
So it's not going to be something that, a clinical team normally brings up. But I think this is worth discussing.
Yeah.
Thank you.
I know that the physicians and MAG had a great difficulty with us. They said they're at that neutrality, but I also go to those meetings and I'm there when they make these kinds of decisions. And I know that a lot of them, because, they spend their whole lives learning and trying to help people stay alive. Same way with nursing. And so it seems like if we were to, other than the person bringing it up, and then that would mean that people have to find out about it some way or other, but to have the medical community or somebody that in ethics in the hospital would seem like that they were saying it's okay, or making it a more viable option to me. And maybe like you talked about, you don't try to get people to go one way or the other, but if they bring it up, you'll talk to them about it, but not to put, even though you wouldn't say you were behind it, not to say the hospital's behind this or any groups behind it.
I think it's, I am a religiously trained ethicist. My background's in theology. Many people are in philosophy or, have a medical degree. So I'm unafraid to go with people where they need to go. If they want to talk about their faith, I'm not going to impose my faith, but I want to be available to them. And so I think that's the question is, if we want to expand this conversation further in Georgia, we should go there and be able to have this kind of conversation amongst ourselves. I mean, we have good folks in the room that we're already in conversation with today. But yes, so I think this is an important area for discussion, and I think there's reasons why it isn't a part of our normal activity. And
what I heard coming up, because I think I tried to be so careful on how I geared this as a learning experience with the committee. Some of them may not have read between the lines and realized what we were going to talk about today. So thank you again for coming on a wing and a prayer and faith in this. But people would say to me, well, we love our animals and we put our dogs down. And I haven't even been able to do that. My husband had to do it and a friend had to do it, my last corgi. I was so upset. And that's true, but see, and as Representative Hilton said, I don't mind saying where I came from, and I hate to quote Newt Gingrich because some people don't like him, but I used to represent him. And one time he said, if we're just a bunch of protoplasm, and he was quoting somebody much more learned than he was that had talked about us, if we're just a bunch of protoplasm floating around, then it doesn't really matter if we kill each other. If there's not some supreme being that oversees this, and I sort of go with that too. It does, maybe not one faith, but if you don't believe that there is some supreme being guiding the universe, then we are just random beats of protoplasm floating around. And why does it matter? I don't know. It's just really hard. Like all of us are suffering with it, and not everybody wants to come forward and say, and thanks, Representative Hilton. Now you know where I am on doing that. I believe we have a soul, and maybe our puppies have souls too. I hope that they're going to be with us when we get to heaven. My husband left me a note and named all our corgis that had gone off and said he'd be waiting for me, but I can't come until I'm in my 90s. So I'm trying to get there. So I hope they're going to be waiting for me. And but maybe their soul is a little different and not made in the image of God. So I don't know, but I'm willing for us to look at everything. And I know people have really differences. And thank goodness that this is one that we can all at least talk about. And it's not Republican or Democrat. It's about human beings and what we can do and what's being done. So thank you again for coming. We've got you out a little later. Sorry, guys, I've been working on this for a while before we got this, and it's a real thing with me. And Ms. McNeil, you have lived this, and we so appreciate that you're willing to come. You comfortable at the podium, or you want to sit down in front, or whatever. We just appreciate you coming. Like you need isn't it? Yeah. Move us toward questioning like you are. Thank you.
Good morning, Madam Chair, Cooper and committee meeting members.
I think you're going to need to pull the microphone a little closer. There we go.
Thank you for this opportunity to speak here today. My name is Jamie McNeil, and my sister Jennifer Bullard died from ALS using the End of Life Option Act in California, where she was able to utilize the medical aid in dying option. This is Jennifer. She was 63 years old, and she was my best friend my whole life. She was so vibrant and so loving, and she was always the first one to be there for anyone. She would be the one to sit at the graveside at the anniversary of the death of a child, holding the grieving mother in her arms. As a first grade teacher, she had a challenging student one year that had autism, and she struggled with him and struggled with him, and she worked through her frustration to find ways to get through to him. And at the end of the year, instead of being relieved that she was done with this child, she asked to teach second grade the next year so that she could have this child on purpose. So that because she wanted to reinforce some of the things that she had taught this kid and some of the techniques so that he'd have a better chance at a successful life. That's the kind of compassionate person my sister was, and she deserved that compassion also. She didn't deserve to suffer. ALS, or Lou Gehrig's disease, is a devastating, progressive, and fatal disease, neuromuscular disease, where the muscles in the body all slowly become paralyzed until finally the respiratory muscles are affected and the person slowly suffocates to death. It is excruciating to watch. It's a brutal disease to watch, let alone to experience. I had a friend who died from ALS from the natural course of it, and she had at the end what's called locked-in syndrome, where all her muscles were paralyzed, including her eyes and her ability to blink. Can you imagine the pain and the burning you'd have before someone realized that you can't blink your eyes? They finally, at the end of her life, had to tape her eyes closed, and she lived that way for a month in total, complete isolation, unable to communicate, unable to speak, unable to move at all. To me, that's the very definition of torture, and my sister didn't deserve to be tortured. Jennifer adamantly did not want to die, but she even more adamantly did not want to go through the locked-in syndrome, and she certainly wasn't going to starve herself to death and put herself through more agony doing that. She was terrified of suffocating to death at the end. So the first thing she said to me when she found out that she had ALS, she said, "No matter what, I'm not taking this disease to the end. No matter what."
Please find out about the end of life option for me. So I did. And at the time, she didn't even qualify. But we knew that at the end of her life, she would qualify. And so she said that just knowing that she had this as an option gave her such relief and peace of mind that she could then focus the rest of her life on the joy of living rather than on the fear of dying. But she still endured a great deal of suffering, as we all did. My husband and I moved from Georgia to California to take care of her for 8 months, and I saw all of her suffering. She had bulbar ALS, which starts from the head and works its way down. So the first thing that was affected for her was her ability to speak. So she had to use her Toby, which is a computer that she had to use her eye gaze to spell out every single letter of every single word she wanted to write. It was excruciatingly tedious and so frustrating for everyone. And because of that, many of her needs didn't go addressed because it was too difficult for her to do all of that. She was also unable to swallow, so she had to have a G tube, a gastric tube put in for her to be fed through. And she choked on her saliva every day. We had to suction her every hour. And she had what was called pseudobulbar effect, where the ALS in her brain was causing her to cry uncontrollably. And I mean wailing, crying all the time. And so the crying, of course, caused all these secretions, which caused her to choke more, which caused us to suction. It was this vicious cycle of her choking on her own saliva. She had to use this very uncomfortable coughing machine because she didn't even have the ability to cough it up. And it was sometimes she would have a mucus plug that it would take her an hour and a half to cough up. It was exhausting for her, and she was just miserable. And these are things that hospice and palliative care cannot help with, even with all of the medications that she was on to try to help. It took us 4 hours to do her morning care. She had these horrible muscle spasms all the time. It was on 8 muscle relaxants a day that didn't even touch it. She had this sensation of shards of glass in her mouth. So she was always wanting me to wipe out her mouth because it felt like she had glass in her mouth. It took us 2 hours to get her in bed at night because however we laid her, she'd have to tell us on her Toby how to position her. And because however we left her was how she was going to be for the rest of the evening or for the rest of the night because she couldn't position herself in bed even. She had no control to even scratch an itch, and she had to use mental games whenever she had an itch to try to deal with that. It was very hard. She couldn't move a hair out of her mouth. She spent over $100,000 on experimental treatment, trying everything that we could for her. And at the end, when she said, "This torture is just too much for me, I can't do it anymore," she said, "I'm done, I'm ready to go." She literally had control over one thing in her life. She didn't have control over whether she was going to die because ALS was what was killing her. She had control over how and when she was going to die. So true to the teacher that Jennifer was, she took charge of her own death and she choreographed every moment of it. And she said she wanted to change the narrative around death. And she wanted to create what she called her beautiful passing. She wanted her friends and her families to talk openly about her death so that we could all process it and grieve together. She felt that if we were all courageous enough to go into the depth of the grief without the fear, as opposed to the breadth of the grief where the pain and suffering is. If we went into the depth of the grief, that's where we would find the meaning. And then the meaning is where we find joy. And that joy is that deep, intimate love that we shared together. 2 days before her chosen date, she invited her close friends and family over because she wanted to look each one of them in their eyes because eye contact was so important to her. She wanted to look them in their eyes and she wanted to tell them to be able to express their mutual love together and to say goodbye to them. And who do you think was the first person in line that day? But that her student with autism who she taught in 2nd grade. He was then 22 years old and he brought his mother with him And they both sat there and they cried as they told Jennifer how she had saved his life by believing in him. It was just so beautiful. For 8 hours, people lined up, and I sat next to her as we had these conversations back and forth with these people. And I've just never felt such genuine, raw, and just real outpouring of pure love in my entire life. It was beautiful, even in the grief of it. And I believe that even God would say that this is the whole reason that we are on this earth, to share this love and connection with each other. I feel like it is the meaning of life itself. And Jennifer deserved to experience this pure love, because had we not had the end of life option, there's no way we would have been able to have that scenario. She would have been in either locked in syndrome or comatose or struggling to breathe. And it wouldn't have been appropriate to have this kind of final goodbye months before she died. That wouldn't have been appropriate. So we were so grateful for that she had this opportunity for closure in her life and to be able to connect so deeply with these people. The doctors take an oath to do no harm. But the most harm that you could have done, Jennifer, would be to have made her live out this disease in that torture for the rest of her life, without a doubt. It would have robbed her of that experience. On the day she chose to take the main medication, it was just immediate family there. We all lit a candle to represent us to her, and we all gathered around her bed. And there was this beautiful serenity in that moment, because we had processed so much of it ahead of time, and we were so relieved that her suffering was going to be ending soon. After she pushed the main medications through her G-tube, I crawled up in bed with her and I held her in my arms as she closed her eyes, slipped into a coma, and peacefully passed away within minutes. I never dreamed that the death of my beloved sister from such a horrific disease would be the most profound and meaningful moment of my life. But it was. She suffered in life with her ALS, but she didn't suffer in death, and she deserved that. Having this medical aid in dying option allowed Jennifer to beat her ALS, because it allowed her to take back her control and to die on her own terms with the dignity and grace that she deserved. As an RN myself for 30 years, I've seen the stark difference between hard deaths, like the end of life, the locked-in syndrome, or cancers or renal disease, as opposed to this peaceful ending that my sister was allowed with the end of life option. That medical aid in dying experience and the gift that it gave my sister Jennifer drives my advocacy today. I am now the voice of my sister. I work for the Georgians for end of life options, and we advocate alongside Death with Dignity to push for laws that give everyone the right for bodily autonomy for themselves to choose their own end of life option under rigorous criteria, of course. My beautiful 9-year-old granddaughter has kidney disease. She's going to need several kidney transplants throughout her life. Now, I've seen people die from renal disease, and it scares me to death to think about her dying that way. At the end of her life, when she has no other option for a kidney transplant, and when the agonizing life of dialysis is too much for her, I want her to have this option also, if she so chooses. And I stress the word option. If it goes against the belief systems of some people, they too have an option to not choose it. And if someone believes that the sanctity of life, it only considers the body, I completely respect that their right to have that belief system, even though I strongly disagree with it and it goes against my belief system, but I respect their right to have that. I'm just asking for the same thing. The belief system of some should not dictate to the belief system of all of us. I believe that the sanctity of life should start with compassion, and we should consider all aspects of our being, not just our physical aspect of our body, but the physical, mental, emotional, and spiritual aspects of our well-being. And that determination is personal and it's individual and can only be made by that individual. We are simply and respectfully asking for the right to choose this medical aid in dying option for ourselves and no one else. No one should be forced to endure endless suffering when there is a compassionate alternative. We all deserve that. Thanks again. I appreciate your time and consideration in this very important matter. Thank you.
All I've got to say is she was one of the most fortunate people on the face of this earth to have a sister like you. To be with her through that travels that she took till the end of her life. And sometimes they say the family you choose is better than the one that you were born with. I think I'd like to get in the line to have you adopt me as a sister, to know that somebody, whether I chose a different way or not, would be there for me. Thank you so much for that. Representative Sharper has a question, and when you get through answering his question, you say you're now advocating for this group. I'd just like to know how y'all are reaching out across Georgia, because if there's a study been done or a survey that says that it's really something that many, many, many older people in Georgia, in all areas of our state are really concerned about and, want us to change the law, or if it's just pockets, or if they're getting education, I'm just curious about how the word gets out, like Representative Sharper was earlier.
Go ahead and answer that first.
Okay. Okay.
Galo has been doing for the last year or so an education program and trying to do, more education. It has to start with education. It's a new topic, and people have to understand it and to be able to ask all these questions, like you say, it's important. So we just kind of started. I've had to back off a little bit because of the health issues of my granddaughter, so I haven't been able to do a whole lot rather than this, but I do think they're trying to do some education program first.
Because I think that's a problem about availability of people, professionals, and all people that are needed to help people through this, especially outside Georgia and the metro areas. Georgia's a very rural state, and we struggle just to get medical attention for the people in those areas, and we're working on it. But it takes a long time to educate a doctor or get a clinical social worker that's trained in this area to reach all the training they have to have. Okay, Sharper, James Sharper.
Thank you very much for sharing your story here. And I've seen all aspects of, death with people. It'd be hospice, may it be, within seconds or minutes. But I want to be clear, and just for my committee members, okay, we've had some great information talking about palliative care, DNRs, all the different options with Ms. Kinlaw with her information. Very good information. If we really look at this and understand the whole process, that is just like not an overnight thing of making these decisions. There's a lot of thought process going into all of these options. The MAID program, there's a lot of good options, and there are some things that are going to have to be in place when we talk about, I'm hearing everybody talk about the mental health part. This clearly shows, even just the DNR part, that's going to be something that's looked into the mental space of a person before they do that. Also in here, it shows clearly that somebody just say, well, I feel bad and they're not doing good mentally, that, hey, I want to end my life. There are a lot of things, safeguards in this information and this information, that's going to say, okay, if you want to do this, you got to go through a lot of hoops to do it to make sure it's what you want to do. And the biggest thing you said that kept on going out to me is, for one, the quality of life for a person, knowing that, okay, I have a DNR, I have a terminal illness, and I don't want to go through that suffering. I'm okay and peaceful to exercise my option. Everybody here have options every day: where you want to eat, where you want to sleep, what you want to drive. We have so many options in our life. But then the option of saying, you know what, I have peace. I don't want my family, wondering when they were going to get that call. Because there are people that have DNRs for 5 and 10 years. They outlive a long time. I mean, like all of this, or you have a person that can suffer a very long time and then dive deep into the family not having to make a decision. When I'm telling you guys, I am mentally capable. This is the option that I choose. Nobody's forcing it on me, but I want this option. So we got to understand, regardless in a sense, a lot of times of what our sometimes spiritual beliefs and other things are, but we want to give the person to have the freedom to have an option. We're not encouraging them to do it, but if they took away all of our options, we wouldn't like that. So just keep that in mind, that this is a serious option for sure, but it's another option that you have in your life to go along with all the other options we have in our life. So if a person wants to choose a best quality of life for themselves until they're gone and can make that decision, I think they deserve that option. Thank you so much.
Thank you. I appreciate that. Just a comment. It's my son-in-law had an accident and broke his neck, and he's partly paralyzed. And he lives in California, and he's in excruciating pain all the time. And he was suicidal for many years after his accident. It's not an option for him. He can't even go and ask for it. It's not an option for him, even though he was wanting to. He talked about suicide. He talked about it all the time. We got him help. We did all these things for him. It's not an option. So there are safeguards in place for these people with the mental illness. You can't just say, oh, I want to die, and I'm just going to take this as an option. It's not allowed, so, and to talk about what you were talking about with the medicines being delivered. Just in our case in California, they had the pharmacy send it to us, and we had to sign for it. An adult had to sign for it. So we had to have it. They gave us a very specific instructions on what to do with it. And they said, if we choose not to use it in the end, there were very rigid requirements that we had to go through to get rid of it for them illegally.
Questions that's come up is that, and Dr. Mims may be able to ask us that when we get to her, is what are the safeguards? Who enforces this? Where does that piece of paper saying you want that, and that somebody, and these things that the doctors have to say that they have okayed it and signed off on it, who checks on that?
Well, the
Like in
physician
California.
in California, when she first had ALS, she went to her doctor right away and said, I want this as an option. He said, you're not eligible for it right now. She said, okay, I understand that. So he was the one to make the determination, you're not 6 months out yet. So when you are 6 months out, then yes, you will be able to utilize it. But he was the one who finally at 6 months out said, I think you're 6 months out now. And so if you want to do this option, you're allowed to. But even at the beginning, still when she was suffering, she still wasn't eligible for it.
So in California, I guess, and maybe different states, there's no oversight group, no ethics group that has these requests go to them or checks on it to see.
Well, we worked specifically with a social worker who took us through every single step, and he told us all the legalities of it, what we needed to do. So he was the one who was, did the safeguards to make sure that we, went to the doctors, all the first one, the consulting doctor, and that we had to go into a room. She had to go into a room alone without any of us there to make sure she wasn't being coerced. that kind of thing.
Okay.
Just
All
want
right.
to add to that.
On that one question, Dr. Mims?
Yes. So in the presentation I had, there was the physician form, and that was from the Georgia Department of Public Health. So each state that passes this as a law, they designate state forms that have to be completed and filed as part of a registry. So there is oversight in that sense, that it's not just floating out there in medical records where no one knows what's going on.
But the follow-up about people using them, or, is there one doctor ordering and okaying, 50 of these, just, and nobody ever checks on it? I mean, we have had that a problem with that in the past. So there doesn't seem to be any, I mean, you don't want the state in it too much, but some oversight about how it's being used. It seems pretty loosey-goosey.
Well, we
The
do
user,
have the
local firm.
the Pharmacy Board for Prescriptions Narcotics oversight. We do have that. So these medications would fall into that.
Of course.
So there is that oversight already in place.
Okay, so pharmacy board would know.
It was the Georgia Medical Board that oversees the prescription, the PDMP,
Yeah.
Prescription Drug Pharmacy Monitoring Program. So we do have that oversight. So if there's abuse of our narcotics by physicians, that we do, that oversight does already exist, and this would fall into that.
Okay, all right.
Thank you.
Okay, Representative Hilton, did you have a question?
Yeah, thank you, Madam Chair. Yeah, just if Ms. McNeil, do you mind? And while you're walking up, I just want to echo the chair lady's comments. You are an incredible
Well, thank
family member, sister, and can you put her picture up if you have it one more time? I just want the committee just to.
He had a glare on, so.
There you go.
There we go.
Beautiful. Beautiful.
That was her.
Sharing that. Representative Sharper talked about options, and I think you've heard us touch on this subject. My concern is, and I'd be curious to ask you if you don't mind sharing. I assume in California it's private pay, like it would be proposed here. So that limits the options, right? Just to those who are able to afford it. In your belief, should Medicaid or other public programs pay for this?
Yeah, that's a tricky question. I think as it becomes more normalized, as people see it happening more and more and become more and more comfortable with seeing, oh, look how easy it is. Look how peaceful it is. I want my, my family member to have this peaceful death too, or I want my death to be that peaceful. I think as it becomes more, people become more aware of it, I think they're going to see that it is part of the whole medical. I feel it's going to be part of the whole medical thing. And yes, I do think in the end, somewhere down the line, it should be an option like everything else. Is palliative care, they pay for this, they pay for. Why not down the line? There's a lot to be ironed out for sure, but down the line, I feel like, yeah, it should be paid for eventually.
I'm keeping the theme of options.
Everyone can have access to it.
Thank you. Thank you. And again, in the theme of options, would you have travel, say it wasn't legal in California at the time, would you have traveled to Oregon or Washington?
Absolutely. Absolutely. 100%. In fact, there's a woman here in Georgia right now, Sarah Ruiz, who has ALS, and she's contacting GALO saying, what can I do? What can I do? It's like, we don't have anything here. I'm sorry. You can go to Vermont. So she called Vermont and they're like, we can't do anything. She's going to have to go to Switzerland. She has 4 young kids. How are you going to take up 4 young kids? This is a process that takes months. You're not going to just take your whole family over to Switzerland. So it creates medical refugees. And to me, personally, there's no way I would take this disease to the end, and I would go and get some Tylenol if I had to. It forces people to commit suicide on their own, which has a stigma attached to it. So it's not that they aren't going to do it when they're like this. It's that they aren't going to do it legally. They shouldn't have to go through that. They shouldn't have to put it through their family through that. you know.
So some states don't have a residency requirement, but they do have you must be there long enough. I'm trying to understand why she went to Switzerland or not.
Or Switzerland they have different requirements.
Okay.
And so I think I'm not sure what it is, but they would allow her to go at any time as long as they can show suffering. She wouldn't have to be 6 months out type thing.
Interesting. Okay, got it.
So
Thank you.
they have a different. Any other?
And you have the information that Amber was so kind to research for me. It seems to be predominantly the people that have used it in different states are highly educated, white, urban area, little over 50% men, women, but very little of the kind of makeup of our state and the size of our state that where it wouldn't be available in the rural areas. And so, it's not available to everybody.
But everything's not available to everyone to begin with in any program. The palliative program is not
Right.
widely available. We have to grow. It has to start somewhere. So you start it somewhere and then you grow to be able to get your infrastructure in so that you can make it so that it is available.
Oh,
But you know that.
I do. I'm trying, sometimes as chairman, I will ask questions to try to put ideas to other people's minds so that we can look at both sides of the issue, because we're not allowed to write laws for just one group of people. I mean, we have huge
Right.
restrictions around it.
Okay.
When we make a law, it becomes, or it's for basically everyone in our state. And I'm just being realistic about, what seems to be. The other thing is that it seems like in these other states that they did it, but they're not growing hugely, that they got people to take, either for whatever reason, lack of, it really wasn't what most of the people aging or people in their state wanted, or it doesn't fit, or they quit educating people, whatever. It seems like they had a big startup, but number of people compared to the number of people in their state, it hasn't grown that much. I'm just
That's because
observing what the stats.
Yeah, it's an option. It's not something that we're advocating for you to do. We're just advocating for the option for you to be able to do it. That's different than.
If people are not even aware of it, they don't know
Right,
that.
right.
Yeah.
It is, but as it's a new concept, and as it grows, we've got more and more states that are legalizing it, and so as that happens, people are going to start asking questions about it, and this right here is conversation about it. That's what we need to do, is start the conversation. It takes years, we know that, but we need to start the conversation.
Yeah, and you're right. That's why we're getting educated. And
Right.
I will say to the committee, and the states that have it are up north. They are states that have many more schools of medicine, further ahead than we are on having lots of MDs and people in their state per 100,000 than we are. And with social services, they have more robust social services all over their states. I mean, if you look at the states that have passed it, whereas we're lacking. So, I mean, not because we want to be, and I know how hard my colleagues and all of us and the people around our state are working to improve that. And we are making a difference. I understand on palliative care, on a national survey, we have come up. I think maybe we got a D before for palliative care. We now are getting a C, and we're not 50th, we're 38th as the programs try to go. Yet, Northside has a program, but two of its satellites in more rural areas tried to have robust programs, and I think they eventually closed. It's a problem in our state. So,
I understand.
Representative Washburn, trying to get to you.
Thank you, Madam Chair. Ms. McNeil, I want to join my colleagues in expressing certainly the commendation to you for the love and care you gave to your sister.
Yeah.
And I identify with that. I have three brothers that I love very much, but I just want to join my colleagues in commending you and in commending you for explaining to us how she suffered and what suffering she was facing toward the end. I think that is a dramatic explanation to us. To go to Representative Sharper's question and comments to us, the idea of options and the idea of allowing someone to be rescued from the kind of suffering that your sister faced. I realize this is just an extremely difficult question, of course, but compassion and the idea that we impose and force people to face that kind of suffering when another option could possibly be here. And I know this is a difficult question to deal with. I do have one question in this, and pardon me, Madam Chair, for the lengthy comments. You mentioned the 6 months time frame, and that her physician said, well, you're not there yet. I wonder if she had been allowed to have access to the drug prior to the 6 months period, do you think she would have chosen to want to end that peaceful life as you described?
She absolutely
life peacefully as you
absolutely didn't. We talked daily about her death, and she said, when I'm ready. And she even said at the beginning, I'm not sure for sure that I'm going to take it. But just knowing that I have that as a backup to where I get to the point where she first thought it's going to be when I can't scratch my first itch. And then she's like, okay, no, I can handle that. And then each time she's like, but then when it came to a point, each day she lost something new, and she just kept going and going and going. And then finally she just said, and she even made the date a couple of weeks before she actually did it. So she had plenty of time to think about it. She got the medication about a month and a half before she actually did it. So she had the medication. You're allowed to have it for 6 months. And she had it. She wanted to have it in case whenever she decided. And she didn't for a while because there were things that she wanted to see. And at the end, her son just got married and was going to be having a baby, and she wanted to hold that baby in her arms so bad. And she just said, I can't do it. I can't do it. I can't stand the suffering anymore. So that's when she chose to do it.
Question, Madam Chair. And I'm not from the medical, I don't have a medical background. And so some of the folks on the committee that do, and to you as well, would there have been palliative care available to your sister that would have completely eased her suffering and ended her suffering from what you have described?
She was on hospice. And so we asked for stuff. We had her on so many medications, believe me, muscle relaxant stuff to help dry up her secretions so that she wouldn't choke so much. And they helped probably 10%, maybe. They didn't do it. And so the palliative care, and even with when we asked at the end if she could have some Xanax to help her, because believe me, there's a burden in picking your own date to die. There's a huge burden in that. And it weighs heavy when you've got kids and grandkids that you're trying to decide, trying to say goodbye to. It's not an easy decision to make. And so I forgot what I was going to say. Anyway, she decided, at this point to just do it. So what was your question again, Lee? Oh, the Xanax. So we did try her on Xanax. And they allowed her to have one a day. And at the end, we said, when she's a little bit more nervous, can she have, a little bit more twice a day or something? They would not give it to her because of the regulations. It's like, are you kidding me? They wouldn't even help her.
Well, I think
emotionally
also
get through this.
It occurs to me that no matter what the palliative care, no one would know but your sister whether or not she was getting relief. Is that
right?
a fair say?
And she wasn't. And palliative care is not going to keep you from getting paralyzed. When you have ALS, it's going to paralyze you no matter what you do. And that's suffering. I mean, we tried to just not move or talk with your eyes. I tried the Toby machine for 2 minutes and I was like, oh no, it gave me a headache right away. I can't do this. It was so, it seems like a little thing, but it's not. All of these things adding up were huge to her and her suffering.
Thank you again for your testimony and for this very vivid explanation of what she faced in her life. And thank you, Madam Chair.
Ms. McNeil, I hope you can stay till the end because we got a couple of people want to ask you questions, but we need to move on.
Yes, thank you. I
And-
appreciate your time.
Okay, and we really had the opening is I asked people to come from palliative care and hospice to give us, and we had Dr. Mary Mosley with Kaiser. They have an active palliative care program. And so, Dr. Mosley, are you on
Good morning, Madam Chair and committee members.
waiting for us?
Yeah, no problem. Madam Chair, thank you for hosting this meeting. I sincerely appreciate all of the personal stories shared today. As previously stated, my name is Mary Mosley, and I am here with my colleague, Mr. Anthony Davis, who is one of the amazing social workers that we have in our palliative care department. I have practiced medicine in the state of Georgia for over 25 years, including the last 18 with Permanente Medicine. During that time, I have been a board certified home-based palliative care physician, serving exclusively Georgians on the south side of our Atlanta metro area. I am grateful to be a part of this discussion today. As a reminder, I'll be speaking from my own experience and expertise and not on behalf of Permanente Medicine. As an introduction, palliative care is specialized medical care focused on improving the quality of life for people with serious, chronic, or life-limiting illnesses. It addresses the whole person, managing symptoms such as pain, shortness of breath, fatigue, and emotional distress, while also supporting families. Unlike hospice, palliative care can be provided at any stage of illness, alongside curative or life-prolonging treatments. The goal is to relieve suffering, help patients maintain dignity and function, and align medical care with a person's values, goals, and preferences. Ensuring equitable access to palliative care is essential in policy discussions about medical aid in dying because without it, patients may feel pressured into life-ending decisions simply due to gaps in care. Palliative care provides supportive care through providing relief from physical suffering, but it also addresses the emotional, spiritual, and family needs, helping patients to feel more comfortable and less isolated as they navigate serious illness. By focusing on quality of life, dignity, and patient-centered goals, palliative care can sometimes reduce the desire for hastened death while respecting the autonomy of those who continue to pursue medical aid in dying. One of the most important goals of palliative care is to provide support so that patients can make a truly informed choice about end-of-life options. When palliative care services are underfunded or inaccessible, requests for medical aid in dying risk reflecting disparities in care rather than genuine autonomy. For this reason, expanding palliative care must be seen as a public health and equity priority, ensuring that medical aid in dying, where legal, is considered within the broader framework of compassionate, high-quality end-of-life care. Thank you.
Anybody questions for the doctor? Not at this time. Okay, Mr. Davis, you're certainly a rare bird in our state that you're specialized in this in social work, and I appreciate you sort of dedicating your career to this. So thank you very much.
Yes, Madam Chair, thank you so much, and thank you to everybody here. I appreciate even being here as a social worker, and I think this is a very serious, controversial subject, even for social workers. I want to kind of explain what a social worker does in palliative and hospice. I've worked in hospice, and I'm currently in palliative care. So in palliative care, we're there for support, we're there for resources, we're there for psychosocial support, but we are not therapists. We are not required to be licensed clinical social workers. We can be just a master of social work with a license in social work. When we talk about hospice, the challenges that I see, and when we talk about medical aid and dying, is I am always for autonomy when it comes to patients. My concern is when the autonomy is pushed because of other reasons, and many reasons that I would see would be resources, as we've discussed. Whether it's resources for mental health, a social worker in hospice is also not a therapist. They do not have to be a licensed clinical social worker. The other piece of that is that the doctor is not always making visits to these homes. So I have literally had a patient tell to me that instead of leaving their home because they didn't have access to resources to have caregivers in the home, I'd rather die than move into a nursing home or assisted living facility. And once you assess further, you find it's not death that they're wanting, it's the lack of resources. It's the fact that they don't have the things needed, whether it be transportation, whether it be food, whether it be caregiver support. Sometimes it's the fact that they don't even have support from their family. And so my concern would be definitely mental health. It would be the resources to make sure all of those are in place and then having this as an option, but making sure that they have all of those things in place before this option. And so as a social worker, as I said before, I'm all about autonomy, but those would be my biggest concerns is education as well to the team of hospice. This is new to hospice. I know if I was in social work and hospice like I used to be, this would be uncomfortable for me. I haven't always been a licensed clinical social worker. So having those conversations, I'm not really qualified to do grief counseling. We do supportive counseling. So when we talk about, end of life and making these decisions, you also have to make sure that people are not making these choices, as I've heard before, for a way out. So that would be my end of it as a social worker and what my concerns would be.
So what you're really suggesting is that if we were to have a bill put forward and we tried to move it through the legislature right away or something, that we would sort of maybe be, or would be, getting the cart before the horse, so to
Yeah.
speak. That really, that we really ought to work as we are trying to do to make more hospice, more palliative care groups that are staffed and capable, and patients all across our state to have more access to those services first, so that their reason for wanting the other one is just because they have a lack of options. Is that
Yeah.
correct?
No, I would totally agree with you, Madam Chair. And I think, just again, like you said, kind of cart before the horse in the sense that, as we've talked about earlier, in rural areas, they just don't have the resources needed. I can't tell you how many times I've gone into rural areas and even getting behavioral health, because again, I'm not a therapist in that role, can be hard, whether it be because of cost, access, whatever it may be. So it's just making sure that they're not making that decision based on lack of resources or a family member even kind of pushing it a little bit because maybe they can't handle taking care of the patient.
Well, and I think that's one that Representative Hilton sort of brought up in the very beginning, was what about the disabled or the handicapped? And there are those questions. I mean, the states that have it where even if they're going to do it, you have to be able to administer the drugs to yourself. But the other thing, with patients like that, the possibility of outside influence. It's why I was sort of asking about if there was anybody checking on how things were done to see if decisions really were being made without outside or undue influence earlier. Are there questions for Mr. Davis? we do have one last presenter and trying to get back. We'll get back to Dr. Mims if you have any things for her questions for her. No questions?
Well, I have one, but
Well, what is it? Go ahead.
okay. So much talk. But, just listening to, the presentation there, and we have the options. It's not the patient's fault or a person's fault if we haven't done what we need to do on hospice and palliative. When you have Oregon and these other places has been doing it a long time, it's the fact this is the opportunity for us to get ahead, at least talking about it, because it seems like we're behind either way right now. So I think that even having that option is something we need to look at, but also make sure we're not holding something off until we maybe get the other stuff that we've already had a long time to get in order. So I just want us to be in that mindset. We have the opportunity at least to get ahead and let's talk about it and have this real conversation. Thank you.
Okay. Thank you. All right. Thank you, Dr. Mosley, and thank you, Mr. Davis, for holding out and coming in with us. We appreciate you doing that. And thank you for the service that you give to Georgia patients. Kaiser is not all over our state. I wish it could be and especially now that I've learned how much y'all do with palliative care and helping patients, I wish that service would be available all over our state. So thank you very much. And we're going to go to Donna Morgan. Ms. Morgan, you ready? And thank you for holding on to tell us about hospice.
Yes, Madam Chairperson, thank you for having me with your group today. I'm honored. I have a 31-year-old child. My husband and I, a science teacher, newly retired, and our child grew up hearing about death and dying his entire life and said most people don't talk about it so much. So this is primetime TV for me then. So thank you for letting me be part of it. I'm a registered nurse by education and experience. I've been in hospice care for over 30 years, and I've had the fortune of being the CEO of a large nonprofit hospice located in Georgia. I'm also a board of directors member for the Georgia Hospice and Palliative Care Organization, a statewide hospice membership organization. So if we talk about accessibility of hospice, there are 299 licensed hospices in Georgia. They are highly concentrated in the more urban areas, and the rural areas do have less access, although every county on the map does show as having access. The hospice provider just might not be located in that county. And in fact, that's true for us. We serve many rural counties where there is not a hospice in that county, and we make the drive out to those homes. So hospice care is generally available. As we've discussed, and so many of the other presenters have referenced hospice many times, hospice eligible patients will have a prognosis as best as anyone can determine of 6 months or less should the illness run its normal course. And the average length of time a person might spend in hospice care is 89 days. For some, they may live longer. They may live a year or more if they remain eligible. And there are many, far too many who die in the first week of life. And for instance, our statistics are currently running 70% will die in the first 7 days. And that tells you how quickly that can progress by the time someone comes into hospice care. Hospice care is available to people of all ages from newborn all the way through, and cancer is about 40% of most hospice programs care. And as we've all become more experienced, we've learned how to care for far more illnesses, such as the neurological diseases that have already been referenced. Care is provided wherever a person lives, majority at home, but many also in long-term care facilities, hospice inpatient facilities, the unhomed, wherever they might be, a hospice will go there. The physical pain and other distressing symptoms can often be managed. The large majority of patients can achieve pain and symptom control. But as the family testimony we just heard attested to, we can't control everything, even with the wonderful aid of social workers and chaplains, experienced physicians and nurses, we sometimes cannot take away that mental anguish. And people might choose to do palliative sedation, which I believe Dr. Mims referenced earlier, and they may choose to live in this twilight state until their death, which is typically a short period when they select that. And then we don't have people that let me start this. We do have people come into hospice who are asking to die. We have people that we admit who will say, when will you give the medication? When will you give the shot? I don't want to live in this pain. Since it's not an option for them, we always say, let us help you with your pain. And I will tell you that most pain and symptoms can be managed medically in the majority of patients, but we can't take away all of the pain. Hospice is generally affordable. It's paid for by Medicare, Medicaid, commercial insurance, government insurances like TRICARE and VA. And then there is also a federal and a state regulation that require a hospice to admit and care for eligible patients regardless of their ability to pay. There are some programs that do have sliding scale for people without insurance. And of course, the state has opened up other pathways to funding, everything from the Affordable Care Act options to the Pathways program through Medicaid. And Representative Cooper and I had a wonderful conversation about that on Saturday. So now we get to the root of it. Suicide already does occur in the hospice patient population. Some of it's less detectable. We may have people that choose to stockpile their medications. We have safeguards in place. The nurses go to the homes, they count the medications, they refill them appropriately. So there's not a large amount of medication in the home. It's just that it's easy to stockpile it if you have that intent. And women statistically are more often likely to take pills to take their life. There are certainly a myriad of other ways to do it, but men typically do it by gunshot. And I think that you can find how distressing it would be for hospice staff and family members to come into a setting where someone has died by suicide by gunshot. The reasons that people in our experience have taken their own lives tend to be due to loss of independence or loss of control. They may be very uncomfortable with accepting physical care from a family member. They don't wish to be a burden to family members and to friends. They don't want to have to leave their own home and go live in another setting. As wonderful as many long-term care facilities can be, they're not always that affordable for people. And also it's often not the environment someone might choose to live in who's lived so independently the rest of their life. Despite the access of 24/7 caregivers, registered nurses, physicians, social workers, and chaplains in hospice care, people often do still look for other methods to control their suffering. Let's see. When you think about responding to a death by suicide, the moral distress that causes for the team members is horrifying. We have a small branch in Alabama, just across the Chattahoochee River from our main office here. And in just 2025 alone, we have had 2 men die by suicide with gunshot wounds, and the same team was assigned to those patients and had to respond to that home. And that's distressing to see the physical injuries. It's distressing to think about the cleanup of that. And those are the things they're faced with. So we have a lot of support in place to care for our own and the family members when this happens. When I listened to the different testimony, it came to me that medical aid in dying feels very similar to medical marijuana. Very different outcome, but still very similar in the sense that safeguards were put in place for the use of medical marijuana. And we have had only one patient out of all of the time that it's been available request that. And they actually died before they could go through all of the processes to get it. But at least it was there as an option for them. So, and we don't offer it, we don't bring it up. But if people ask us, we can say, well, yes, that is a choice. And here's the way to get to the website. Or here, let's look it up and you can learn more about it if they don't have their own access to look it up. So we have found that most people do still naturally don't have to resort to even the medical marijuana. So this may be just a thought similar to that, available, a right. We're born with so many rights, and yet we don't necessarily have the right for this. I didn't come into this with an opinion, by the way, but some of the things I've heard today have flexed me towards realizing that we can't fix everything in a person's life, death, and suffering. The family caregiver testimony a while ago was so powerful, and it's just something that I think we should take that into consideration, obviously, or that this committee should. Also, and I would be glad to make available the contact information for the Georgia Hospice and Palliative Care Organization so that there could be more hospice and palliative care providers engaged in this as your conversations continue. Thank you for allowing me to speak, and I'm happy for questions.
Okay. Do we have questions for Ms. Morgan? Well, thank you. I would hope, and that as we, think that we can work on palliative care and the availability of hospice, that if going forward, if y'all have suggestions and, feel free to let us know. If you have suggestions that we might need to change to make hospice care more effective, or changes that need to be made. We are not out there doing your work, and so we don't see those changes that might need to occur. The same with palliative care, and that if we all work together, I would hope that we could improve the availability and the care from both areas around our state. And so if nothing else out of this meeting and what we learn, we would be able to help y'all do your job more effectively going forward. So I really appreciate you taking the time, hanging on with us, and being straightforward. And I was glad to hear, and like you say, we can't take care of the pain and everything, but that you felt like we had been able to, with all the new things available for pain, handle about 99% of it. Do you still feel that way, other than with situations like ALS and all?
Yes, ma'am. I will say that hearing the family testimony, I was distressed to hear that Xanax would have only been made available once per day. That's not even a medically way to prescribe it. Can be much more common. People take it more frequently. So I think the main thing you might find between providers, medical providers, is differences of thought about medications. And so each hospice, even though we all follow the same regulations, will have variety on how they perceive medications should be used. The other thought that I had is I have a 52-year-old brother-in-law who is a quadriplegic from a bicycle accident. He speaks of taking his own life nonstop, but he has no method by which to do that. He wouldn't be able to self-administer a medication. So like ALS and some of these other diseases we've spoke of, there might be some consideration, should this one day progress, that a person who is mentally able but not physically able could have some consideration.
Okay, thank you very much. Any questions come up? You've got one? No?
But at the end,
At the end?
no.
Okay, when it's just us?
I mean, well,
We're
I'm
going-
gonna ask you now, but I didn't want to take up her time.
Well, okay, thank you so much for hanging on. Okay, I thought y'all might have more questions for Dr. Mims. Yeah, okay, Dr. Mims, come on up. Okay, guys, here's your chance to ask that last burning question or couple of questions of Dr. Mims, because she is the expert on that. Okay, Sharper.
Okay, thank you once again. I think this is a lot of information, great information all the way around the board. But Hilton, you was mentioned about, maybe the cost, different things on the cost. And we're just going to put it out there. This is an open committee day, okay? This is open committee day, all right? But when we're looking at the money, I'm pretty sure that insurance companies and others, instead of a person racking up $10,000 a day or $5,000 a day or whatever it is, if they know this person has this as an option, they complete all the checks are done. I'm pretty sure they would be like, okay, well, let them do it from a financial standpoint. And then we've also see that we have a small demographics and a small number of people that's doing this, across the state for what we've seen. But I think if we were able to get to this point in Georgia, that we can tailor make the program. There may be other things that you have here that they're doing in other cities, in other states, but we can also have the option to tailor make this thing to what we think it should be as a governing body as a whole. But like I say, I'm still for people having options because that's their right to have an option. And I think it's our duty to give people good options that we have vetted if we get to this point where we can do this.
The question, and that the question would be, in the states that do have this, have the insurance companies stepped up and are they paying for it?
And I don't know the answer to that question.
Okay, because I mean, that would be one way for us. Amber, can you look at can you think you could find that for us? And we can get it, I can get it out to the committee to see if that really has happened. That's a good thing to put forward.
I'd also say that from Kathy Kinlaw's presentation, she was talking about from the perspective of people who were in the hospital. The people who used MAID and died, 91% died at home. So they weren't in that high cost burden. Donna mentioned the fact that there's suicide occurring. So I just Googled what's the percentage of suicide in Georgia in people over 65, and we have 17 per 100,000. And suicide is a option that people take, and not all of them are on hospice. So it's not that people don't have a way to end their life. But there's ramifications for life insurance and other things if you die by suicide that people may not choose. But the reason they wanted to do MAID was the loss of autonomy, the loss of dignity, diminished quality of life. Those were the three things that were above 90% as to why they made those decisions. Thank you.
Okay, Representative Howard.
So thank you, Chairman Cooper. Thank you for this discussion. It's pretty robust and unexpected, really. But I'm glad to be here to hear this. This debate seemed to be over, for me, moral, ethics, faith, that kind of thing. But one of my other concerns was on your slide, and I think we alluded to this, 96% of the persons that take advantage of this is non-Hispanic whites. Is there a reason? Is there an access problem in the disparity? Is there financial issues? Or is it just maybe something that persons of other races have against assisted suicide?
Thank you for making note of that. This was actually Oregon. And so the demographics of Oregon are reflective there. So it showed the percent that was non-Hispanic, white, or over 90-something%. But in Georgia, our demographics are different. They have less than 5% Blacks in Oregon. So the percentages are really just reflective of what it looks like in that state.
So what about in some of the other states?
And I don't have the data from other states.
It would be interesting to know
Yes.
that. Yeah.
Get what Amber made for me. It seems to run pretty close to some highly educated, white, urban is where a lot of it, people that take advantage of it.
And making that personal decision. So those who are more reflective of their faith may not choose to make that decision.
And I would think that, considering we are Bible Belt, and there really aren't any southern states that have passed the bill. Most of the states are northern or west coast or coming across. I would certainly think that faith and, what'd you say? Go ahead.
I'll wait to be heard.
No, okay, I recognize you. Okay.
Chair, I hate to bring Paul. I'll just make an observation. All the states that have passed that are blue states, the one red state where it is in effect was due to a court decision, and they are currently actively through Senate Bill 136 trying to repeal it, which has passed the Senate and I believe needs to get through the House. So again, just an observation. The observation, and Representative Sharper, you've hit one of my concerns on the head, is the perverse incentives created by the insurance companies who would say, why am I going to, I'm going to cut off spending $100,000 to keep this person alive in favor of MAID, but I'll end with a question. And the question is, the drug cocktail itself, does it contain any paralytics, and how often does the cocktail not work or is ineffective?
So as I kind of showed in the data, it works nearly 98% of the time. The people do ultimately die from it, but it may take a little longer. Let's see, in terms of, I'm sorry, I wanted to pull up for you in terms of the medications. They're primarily sedatives, medications that disrupt the rate of your heart. And I'm sorry, I don't have that particular slide set. Give me that one. Thank you. I appreciate your allowing me to indulge in
Take your
this.
time.
So the two medications are dancetrone and metoclopramide takes away nausea. That's their primary other ones on here. Diazepam, which is Valium, morphine, amitriptyline, digoxin, phenobarbital. None of these are paralysis.
Okay.
So thank you for asking that. No, they're sedatives and they disrupt the rate of heart regulation.
So 2% of the time the cocktail does not work, or is
No, you probably have it more accurate than I do. Thank you.
We asked that same question because that was one of Jennifer's
Yeah.
biggest concerns of what if it doesn't work. And he said that there were two people it didn't work on, and it was only because they didn't take it all. So that's what they told us. But he says it's 10 times a lethal dose. So it's a huge dose. And my sister passed away, literally, she became unconscious within a minute and was dead within a few minutes. So that's what they told us.
Thank you.
Questions?
Yeah.
Hey. Okay, wait a minute. Who question?
No, back to Hilton.
Okay.
Oh.
Oh,
Because I'm gonna live to 112 years old and I'm gonna still be in good shape. So I'm just put that out there, 112. But looking at the medications, and I'm just trying to give the knowledge that I have on certain things. Like when they're in the hospice and they give, certain medicines when you're like, it doesn't look good, and they say, we're gonna give you this little medicine to kind of help relax the person. It's gonna take their respiratory down, and it could be a few hours, a little bit okay to tell everybody it's not looking good. Y'all come, this is what we're looking like. That's a more, a lot of times morphine, other drugs, but it kind of just relax you. But this drug we're talking about here is like, okay, you ready to go? You done had time to say, everybody, I'm getting ready to do this. And it's like, it's all in, the respiratory is gonna shut down, and then everything else is over with. So that's the difference of when we're talking about palliative and hospice, that slower process to help you with the pain, but eventually when we get to where they're no thrive of life, no anything going on, where you're gonna help them relax their way on out, versus this, I'm ready, 3, 2, 1. Okay, I just want to put that out there.
yes, that's why I when this first came up, and I tried to see if I had anything on it in the books I had, or my husband, and there was one called The Final Solution. I started reading it, and when it talked about, the first chapter was about all the problems with taking during the war, you could take it. What was it that you could take? Hitler took it. Cyanide. The problems with cyanide, I went, and then I looked up the bill. It was done in 1990. I think I'll just throw this book away. It needs to go. I think it's a little out of date with the kinds of medications they now use. So I decided that was not the one. But the thing is about The Final Solution. I think that our presenter, Miss Morgan, talked about, or somebody did, sort of like a twilight sleep, that they could almost, in the hospice, they could put patients where they are really just pretty much in a sort of sounds like to me it's almost a
Conscious
comatose state.
sedation.
Is that it?
Yes, conscious sedation. That was on my list of I think it's my second or third slide.
Okay, did they do that and use that as a way of, I'm not
Relieving
killing them, of
suffering.
course, not that, but I mean of taking care of any pain or when they're just worn out and tired and ready for the end to come. And I will say, I had a sort of an adopted mom up in Tennessee and lifelong diabetic, never weighed over 100 pounds, and she was down to 80 pounds. And the doctor said she had caretakers around the clock. And he said, Sharon, tell those caretakers not to bring her back. And they had just taken her back because they had round the clock care. And I was paying, not me, she was paying for it. And it was a good gig. And they had moved her into the den so she could be where they were in the kitchen, see the kitchen and coming and going. And I was up there. And before I got, she was down in the bed, in a hospital bed. And I said to the caretaker, come and help me move her up. And then I'm going to get on the road coming home. Well, I know how to move a patient. And so I made sure that the caretaker didn't. And we gently, she weighed 85 pounds then. And I've never heard such a scream in pain. I mean, I still get the chill bumps from it. And I said to the caretaker, I'm going in, I'm fixing to give her more morphine. Call hospice. And so as I drew up the morphine within, knowing I'm not giving her an overdose or anything, knowing at that weight and all, and it was late, I was going to start back about 11 o'clock at night. And I gave it to her, the hospice okayed it. I didn't want to do anything, so tell the nurses I was doing. And before I could get home, 4 hours on the road, going pretty fast, they called and said, she's passed away. Very often they do ease out as not on purpose, but morphine does reduce respirations. They do relax, and it seems like life ebbs and flows. So it is it's an interesting situation how our body works and how things are things. Dr. Mims, oh, wait a minute, got another question. Taylor, oh, Dempsey, wait a minute, Dempsey's first. Go, Representative Dempsey. Thank you, ladies. Oh, okay.
Thank you. We all have had in our family or friends where we have had to go through situations much like what we've heard today. But I think, I don't know if it's the publicity of it, but one of the striking things that I had was your graft. The first 10 years, there were very few. It was under 100. And then the last 10 years, it's gone from that just over 100 to almost 400 deaths. What has caused the increase in the number of these recipients and death? Is it the tweaking to the bill you talked about? Is it the publicity? It's just, that was to me a monumental growth in utilization of these programs.
Probably two things. One is that baby boomers suddenly became over 65 who have more chronic diseases. And so you had more people in those older ages who are the ones who are choosing to use it. And it became more, people became more informed about the availability. So it's the two. We in Georgia, we are a rapidly aging state too, compared to the rest of the nation. And so we have more people who are over age 65 who have chronic diseases and will be in the position to may end up needing to consider their advanced care directives. I recommend, like Chairman Cooper, everybody should have an advanced directive. Everybody needs to do that, to decide if you can't speak for yourself, who is going to speak for you. And if it becomes within the last, if we don't think you're going to be alive within the next year, we want to turn those decisions you've already made into medical orders that can be followed, and making those available for the family, for EMS. We had a yellow dot program in Georgia. So we had many ways of trying to make sure that a person's advanced care decisions are known and operated. But it's a public health issue. Most people don't know about this. They have never heard of yellow dot. They never heard of healthcare advanced directive. They definitely don't know about PULSE. So it is a big public health issue in terms of discussing end of life options. Thank you.
Thank you, Dr. Mims. I want to say, first of all, how much I appreciate COAGE. Y'all are a great organization, and particularly as we go through our budget process, the way y'all prioritize and organize your requests is very, very helpful in the work that we try to do here. And been aware for a while about this conversation and how it came from one member starting and it's grown. So just to refresh me, I want to make sure. So, and when I look on the history in your slides, the ones that and talk about the history in Georgia, when it was adopted by co-age membership to be on their agenda, was there, y'all usually do ballots, so it's usually, so is there a count? I mean, like, do we know how strong this was among the total membership?
I don't have the exact numbers in front of me, but the year that this went through, we had more issues to vote on than we had number of issues that we could take. We could only take 2 in a year. And so this made it within the top 2 of over several hundred people that voted, votes that were cast.
And co-age's membership actually is how large in our state? About?
Right now it's about 994 voting members.
So it was about what? Not even a fourth of the members that would have been there to actually cast a ballot. I'm not discrediting that. It's just that some people don't participate in the meetings and in doing that, but it's a portion of the membership that did it.
Of the members who chose to vote, it came in within the top 2 number of issues that they wanted to have co-age represent them that year.
Okay, thank you. Thank you.
Ooh, all right. I had a note from Donna Morgan that, there's nothing in hospice that they give. If I misled you, the fact that, Ruthie got morphine, they're not trying to hasten death. It's just their intention as pain intensifies to take care of the pain. But anytime you give morphine, if you gave it to us, our respiratory tracts would slow down. Our respiratory rate would slow down. It's just one of the things that happens when you give pain medication. And so it's not intended, it's intended to relieve symptoms. Like when Ruthie screamed that horrible scream, then I knew she was in pain. So I'm going to make that clear. I'm sorry, Ms. Morgan, on the thing to do it and Representative, you bring up a good point, because one of the things I was trying to say before, I'd really wonder how widespread this interest is. I mean, because I don't think there's ever been a statewide or a question on a ballot about this in Georgia. And we are an aging state. I think we have already, they're saying that there's several states that are aging, and they say for a lot of them that in about another 5 years, they will have more people over 65 than are under 18. Well, guys, we're already there. We're ahead. The latest I heard is that we had hit that mark 2 years ahead of when they thought we would, and several years ahead of the other states. So, great power has it, guys. Thank God for hair color. But it is a problem. And as medicine has been able to extend our lives, then people are living. It's like how we thought everybody, when we passed the assisted living bill, we thought people that were going to move into assisted living when they were in their 70s. No, that's not who moves into assisted living facilities, and they're sicker when they come. So it's one of the problems we're having in those assisted living facilities, that they weren't geared to do that kind of care, but they're over 80. It's not the baby boomers that like that. They're living healthy longer, and they're going into assisted living longer. So we've had to change some of the rules about giving medications and those and all because of us living so much longer. So it is something that, our legislatures beyond us are going to have to face with our aging population. So Dr. Mims, thank you very much. I'm sure among ourselves we'll talk about this and see like I say, I think we got some work to do before my feeling would be, but it's just my personal feeling, before we would pass a bill like this, and I know this is not what you want, Dexter, but that we would do everything we could do to make people comfortable and would not in pain and uh, be, so that they wouldn't want to choose this option, I guess I'd say. It's hard, very hard on families, even when they want to honor the person's feelings and all, it's still very hard on everybody surrounding, not to count. So with that, I will say we are adjourned, and I know that Dr. Mims probably, and also I know that people want to talk to you about your sister. And thank you again for doing that. And Representative Howard, I think you want to talk to me before it's a don't go. And thank you to my members who stayed long. We will not, this is it, guys. And I cannot tell you how much I appreciate, because there are seniors watching this. I'm sure all the ladies that are in Johnny Isaacson's son's place are probably watching. I wouldn't tell you that luncheon. It was a very nice luncheon. And since the gentleman had wanted to come and couldn't, I said, well, just tell me, show me where he lives in this big complex, and I'll go visit him. And they said, no, he's too sick. He died that afternoon. But it had been, he wasn't the only one. So apparently they have a very big group. And I have jokingly said, Dr. Mims, since that time, because is what started that small extra group. I'm not going out and tell people how to get involved anymore. No, I'm teasing. I believe that if people know how to be involved in the political process, I think that's a very positive thing. And I will be glad to go and talk to people about how you become involved in political process. And this certainly shows that when a group of people want to do something, they can start this new group and they can do something. And there are seniors, and I thank them for pushing us to have this talk. Thank you very much. We're adjourned.
I'll just put this in your mind that I'd rather be in a situation where I'm with my family member when something like this happens, if they choose this option, versus me hearing that they've committed suicide or them actually commit suicide because for some reason they felt they didn't have this option, because at that point you have other mental issues that you have to deal with after you've been to a suicide. I remember all the suicides that I've been to as a paramedic over the last 30 years. Every last one of them. I mean, I don't suffer with anything from it, thank God, but I remember where I was and where they did it to themselves. So those are things that you got to just keep in mind, that there's going to be other issues that happen. But I appreciate, I didn't mean to take up all the time, but I appreciate today.
I will tell you sometimes when I try to, and I end up talking, I'm trying to lead you all to ask questions or maybe make you think about them. So I wasn't trying to, and I appreciate all the questions and all the thanks, comments from everybody. So what you've had to say has been very important. Thank you very much. We're adjourned.